So we'll jump in so we can make use of this hour together. Thank you everyone so much for calling in today, for joining us. We know all of our time is precious and we are often looking for the best way to utilize times. We recognize there are many other things you could be doing in this hour, and we're grateful that you're all here and that you're doing the work that you do. And hopefully in our time together today, we can support each other, enhance our skills, and have some conversations that open our minds and make connections too. So again, we're the primary care behavioral health special interest group within CFHA. We're really excited for the conference coming up in a couple of months. And while the conference is just once a year, the SIG has activities that run all throughout the year. And for the purposes of our meeting today, we are still using Zoom. So please, sorry, 1 second. So you can always mute yourself if you'd like to, but if you're in between activities, or you can keep yourself unmuted. We really want this to be an open conversation as well. And we really love using the chat. So you can feel free to respond to when people are talking in the chat, and we can all kind of monitor that as well. Or you can unmute yourself or raise your hand. We've got all of those techniques too. If you want to connect with us, you can always reach out to our secretary, who is Samantha Kettle, who's our secretary for the this year in the SIG. And you can always click to join the SIG and within your CFHA membership account. But we don't have a separate listserv right now because we've transitioned to Gaggle. So if you ever need to contact us in the SIG, our emails, you contacting Samantha, or my emails in here too, and I send a lot of the emails too, so you can always reply to me directly. It's great to have you here. And kind of everyone who's a CFHA member is a member of the SIG, and even people who aren't a member in CFHA join a lot of our things. So if you have any interest in PCBH, we want you to be involved with us. So we're here to welcome everyone. We have a couple of announcements, and then our meeting is primarily going to focus on kind of a journal club conversation where we'll be talking about clinical supervision and PCBH. And then we'll have some closing remarks, and we'll be wrapped up by the end of the hour, or if not sooner. If you need to leave at any time, feel free to step out. You can say goodbye in the chat, or if you're talking, that's great too, but we trust you there. So for our leadership team, here is a couple of beautiful headshots. So Brittany, who's also on the call, is here. And we have a couple of other leadership team members join us throughout the meeting. You'll see information coming out from all of us. We all write things too in the newsletter. So we're excited to have Megan as a member at large, Sam as our secretary, Gabby as our ECP representative, and Natalie as our student rep again this year. We have 3 more meetings, including this one for the year. We decided to do them about every other month. And so we're meeting today. Our next meeting will take place during the conference in person. We'll be working with the CFHA team to see if there could be a hybrid option available. So keep your eyes and ears peeled for a newsletter coming out in September from our SIG that will have some information about the conference and ways that you can connect with the SIG and PCBH people at the conference. We'll hopefully be hosting a social hour for networking, and then having a formal meeting with a specific topic or panel, and then a bunch of other things will be coming that will help to point you towards at the conference. So there might be specific trainings or discussion groups that might be of interest to SIG members as well. And a couple of notes on the conference that's coming up in Boise in October. The information about the extended learning opportunities has been disseminated, and registration is open, including for the main conference that's in person, as well as for the ELOs. There will be a couple of virtual options before the conference related to PCBH, including the PCBH bootcamp. And then for the PCBH forum, there will be a meeting that's virtual, I believe a week or 2 before, as well as a meeting and a forum in person on the 13th of October. So you can learn more about all of those extended learning opportunities at the CFHA website, on the integratedcareconference.com website as well. If you have any questions, you can reach out to us or to Jackie within CFHA for more information too. And then we have a small work group with a couple of members who've been helping out here on the call today, where we're focusing on outcomes measurement in PCBH. and gathering some evidence and recommendations for the field to begin outcomes tracking, or just to compile what people are already doing and make some recommendations. We're meeting again next week on August 17th at 9 a.m. Central. If you're interested in joining that, you can email me, and that my email is also in the reminder we sent out yesterday. Great. Does anybody have any questions about any of those announcements or anything about the conference? Feel free to unmute yourself too. Okay.
Kelly, I have a quick question.
Sure.
This is Laura. I think I saw that there's going to be some workshops or maybe an EOL on clinical supervision at the conference. Are you tracking any of that?
I haven't seen one posted that's specifically to clinical supervision in PCBH right now. So I don't know if there was anything in the works. From what's been posted, I think that's maybe the final version.
Okay, I thought Stacy Abide was going to do something, but
sure. Brittany, have you heard anything about Stacy doing one?
I haven't heard anything. It looks like Mark Vogel said she is presenting, but I'm not sure exactly what on the topic. I'd have to browse the website again.
Yeah, she's presenting on some competency work she's done, looking at how you identify supervision competencies. And so I don't know what the name, but it's a session she and her co-author on a potential article are presenting on this.
You know what, I'm looking at the schedule right now, and she is presenting clinical supervision within primary care behavioral health, a community of practice example.
Oh, great. Do you know what day that is, Jackie, during the conference?
That is on Friday.
Okay, great. So it looks like it's just one of the conference sessions.
Yes. Yeah, and remember, we can also add, I can take a look at the ELOs, but we can also always add discussion groups too.
Oh, great.
Mhm.
Excellent. Thank you so much, Jackie. Thanks, Laura, for that question.
Yeah,
For those who are doing or who are supervising collaborative care, there are 2 ELOs on COCM collaborative care, both introductory and advanced skills, including supervision of behavioral health care managers or collaborative care teams. And so take a look at those ELAs. That's a new ELOs. That's a new feature, which is pretty cool. All right. So we're going to transition. Anyone else has any questions, feel free to come back to this too. And I'm going to, Brittany, do you want to start off with that opening question?
Yeah, so just 2 opening questions, and feel free to use the reactions where you can give a thumbs up or raise your hand. Just wanted to know how many people on the call are actually providing supervision in PCBH currently. All right, so we've got a few hands, thank you. And then, oh, wonderful, thanks, Laura. And then the next question is, who on the call has received supervision in providing supervision in PCBH, either super soup or some training? Wonderful, wonderful. So we've got Chris, me, Kelly, a couple other people, Mark, Rosemary. Wonderful. All right. So we've got a good mix of people who are both providing and have received supervision in primary care. And today, like Kelly said before, we want this to just be a journal club and be able to discuss our thoughts of this new outcoming journal and be a brainstorming session for everyone, as this is obviously new information and continues to be added on, especially with the presentation and work from Stacy Obide around even supervisor competencies. I know that's still ongoing work. So we have some starter questions just to start us off. And Kelly, if you'll ask one of the questions, or if anyone wants to open with another question, feel free to begin.
Chat. So I'll put them in the chat. So if anybody wants to pick a question, sorry, I keep accidentally muting myself. So I'll put them in the chat. If anybody wants to pick a question to respond to, they can. Hold on.
And I don't know about you, but Kelly, I'm pretty interested in the people who received supervision and PCBH, what their experience was like and their feedback around that. And I'm happy to share first, just to open up. So I was actually trained by Stacy O'Bide. And so my supervision experience is I was being supervised in PCBH, but also conducted Soup of Soup, where Stacy supervised me, and then I supervised a practicum student. And we use tools like the BICAT and the BHC competency tools to guide our supervision. So those were the main things that we did. We used a precepting model as well in our supervision.
Great. We have a great response in the chat. Chris saying that Chris experienced supervision from Kirk Strassel and was supervised by him while Chris supervised others a long time ago in 2000. They used competency benchmarks for feedback as well as for when the supervision was provided to other people. Very cool. So I was also trained in PCBH, but it was not that structured at all. So thanks, Jessica. Have a good warm handoff. Good seeing you all. Good seeing you too. So I'm a licensed clinical social worker, and I was trained as an intern and then as a unlicensed learner in primary care behavioral health in Chicago and Illinois in an FQHC. And so the program was still building, and my supervisor was an LCSW too. And there was a mixture of clinicians, BH clinicians who were really committed to the PCBH model and trained in it, and a lot of people who transitioned from specialty mental health. And so I received a mixture of supervision from those who were trained in specialty mental health and those who had only worked in PCBH. And we did not use any standardized tools. A lot of my supervision was rooted in social work supervision, in ethics, in clinical practice, in modalities, and case consultation. And there were not any tools related to competency or BICAT used at that time. And my reflection on it's been 5 years since I finished supervision, is that my primary supervisor was very much an integrated clinician in her heart and in her practice. And so she really modeled and supervised me in being an integrated behavioral health clinician. And so she was pretty much a superstar in that sense. But that was not something that was provided to everyone else.
Just everyone, I provided 2 links, one to the BICAT and one to the BHC competency tool, just in case y'all haven't seen that before, or it's a quick access to those tools. Those are used as self-assessment. Often in my work, I filled out one, Stacy filled out one, we compared, saw how it was, filled it out at the beginning, middle, and end of our supervision time together.
I agree with you, Chris. Having vague, unstructured supervision without the targets, it did make me feel kind of lost and unstructured in primary care behavioral health. And then once I became a supervisor, I sought out tools like the core competencies to train other people. But I really had to learn from people in the field who are publishing and writing on this about how to do it. And it was very hard to find any continuing education in clinical supervision that helped me in primary care behavioral health. None really existed. And Mark, would you want to share anything? I see your hand up.
Sure. So I guess what I would say is maybe like Chris, but others, certainly we started doing this back in the late 80s and early 90s before Chris wrote his book. And so it was, but the supervision we really received was at that time we were both doing medical education and integrated primary care. So it was really kind of how do you help providers understand what you're doing, as well as be there available for the opportunities to intervene. And, you know, sort of as the model evolved, we sort of evolved both in terms of what we were doing in the postdoc and what we were teaching the fellows. And I would offer that having that structured experience in like a postdoc is one of the best ways to get that additional experience. But again, you're looking for people who aren't just seat of the pants, but they really understand the model and understand because I think, as Chris and others have written, the lack of fidelity to the model is pretty amazing. There's lots of people who do lots of things that they call themselves integrated primary care, but really aren't. And so having people who understand kind of what is your purpose, what is your model, and then can both observe you in your teaching role and your clinical role, and then have additional supervision to talk about that. And then the other experience we offered for our postdocs is then, like so I said before, supervising a practicum student, getting supervision on that, because it is really graded in terms of having to build that. It's a competency like other competencies that you have to really start at. You're a novice and you build your way up towards competent and maybe advanced expert.
Thanks everyone for giving us a brief summary of some of the things that you've been doing or been exposed to. And so if we go back to the article, I just wanted to open up for conversation around what questions it raised for people, what things that they took from the article that they thought that might be helpful to put into their own practice.
Given that nobody's saying anything, I'll speak up and see if I can start the conversation going forward. I think kind of what I took from the article, I think, were a couple of different things. One is that we don't really necessarily have kind of the supervision or training model per se for this in stone. And we have some theories, we have some clinical experience about what we think works in our system, but I always put the scientist hat on and say, well, what's the good data that will show that if we do X, Y, and Z, that it helps this PCBH provider, BHC, engage with a patient or a team in a way that produces better quality outcomes, prevention, population health. So part of this is, here's what we think works, let's do it and see if we are hitting the targets that we have for our team and for our patients. But we also have to have targets for that. What I also got was that, and I think this is what a lot of maybe different clinics and different training programs struggle with, they don't have people with experience that can actually be a good BHC or collaborative care provider. That's one. But even if you have those skills and you're really good as a BHC, it doesn't mean you're going to be a good supervisor or trainer, because in my opinion, that's a whole separate set of skills. And so at least in our system, our expert supervisors, mentors, trainers, one, they've already been looked at and yep, you're a good BHC, you produce good outcomes. You want to be an expert trainer? We have this whole set of other competencies that we're going to train you to be a trainer. And then we're going to observe you being a trainer or a mentor, and we're going to give you feedback on that so that we at least have some consistency in the way that we think in our system with our patients and our teams, what we need to do to get those outcomes. I think it can be hard also when you're not actually observing a trainee or somebody you're mentoring, because they will come back and they will report they can report what they think they did in an appointment. But if you actually observe them and you compare what you observe to what they report, sometimes those things don't match up. I don't think they're necessarily trying to lie. It's just hard for them to be self-aware. So I think the more that we can have people that have skills, and even being able to share mentors, supervisors across systems or across regions, where you can actually at least listen in to what's going on. You don't necessarily have to be there to observe. I think those are some of the things that came to my mind as I was reading through that article, that we can do better at this, and we should do better. And how can we do this in a systematic way? Because we've got a shortage of supervisors and providers. Okay, that should be enough to get people going.
That really resonates a lot with me in my experience, because I've always worked in FQHCs that were not part of larger medical systems with residency training programs. And I was fortunate to have a mentor who I've been working with since I got into PCBH work, who's really just been a huge resource. I don't know where I'd be without her. But I often find myself wishing that I had access to kind of what you were describing, you know, the supervision of supervisors across systems. How do I find that? How do I access that in a more formal way? Because I've always had to kind of find what I need on my own. So yeah, I think that's a huge need, especially for smaller health centers not associated with educational or larger medical systems.
I think one thing that really stuck out to me is just the reminder about, like, it's not just PCBH that we need to have knowledge of, it's primary care in general, and the intentions behind primary care, the 4 C's, and how we end up weaving that into our supervision and our training, especially because for many of us, that's not included in our schooling or our internships, or even our supervision conversations, and how sometimes we can get so caught up on the clinical pieces that we forget the whole picture and the whole purpose of primary care in general.
And something that comes up for me as a social worker by training and practice as well, is that it's a very new thing to be seeing that in the field of social work, there's even such a thing as a fellowship or a postmaster's fellowship experience, where you have really structured training within a system or within a field outside of, say, like child protective services or specialty mental health, or finding an opportunity to really dive into a field and become competent in it is not something that's really talked about or seen. It's very new that the Council on Social Work Education has now just started to create guidelines, and in a way they're developing their own approval and certification of post MSW fellowship programs, which I know Laura's on the call too, and a few of others of us through CFHA have been meeting every couple of months to talk about how to build programs like that too, to create training and fellowship opportunities for a variety of clinicians being trained in master's programs, but to help them get into this pipeline before they get pulled into specialty mental health, and expose them to integrated care and provide that training that could be modeled upon pre and post-doc fellowships, but for master's level clinicians. And now I work in a rural area. I used to work in an urban area in Chicago, and in a rural area, we're finding, just trying to find new grads, and even the community mental health center is using bachelor's level clinicians as qualified mental health associates to provide their care. There is, in Oregon, it's very hard to find or recruit anyone to work in agencies or in health centers in behavioral health. And so finding somebody who could do PCBH we're excited when somebody applies. We are looking for a great fit and somebody who wants to be trained, and finding that right person by having the supervision of it too. And me envisioning being able to observe them without having patients of my own on the same day is kind of, my health center would balk at that idea. I think that would freak out. And then we would only have one clinician seeing 30 primary care providers patients.
That's an interesting thought too, Kelly, about, we are still waiting on some of the literature to come out about like supervisors and supervision in general, and how often those types of literature is used to push the initiative in your organization. And so a lot of people get pushback from their organizations around, you need to be doing this, you don't need that much time, because I don't understand that this is a different skill set than what was trained in, master's programs or most doctorate programs. We do have a question in the chat from Tanya. It says, I know that answer is complicated, but I would love to hear from Chris and others the most important and actual teachable skill for PCBH supervisors. I can go ahead, Chris.
Yeah, so I'll tell you kind of what my opinion is. I think one, you have to start off with a good base supervisor, somebody who wants to train other people, who has relatively good interpersonal skills. And I think if you start off with that base, that's your starting point. But assuming you're starting with that base, I think one of the things that I think is important is helping that supervisor, one, supervise or train or mentor to a set of specific skills, so that the trainee or the person being mentored or supervised knows exactly what skill set that supervisor is looking for. And the supervisor gives very specific feedback to that. Here's what you did that I liked. It's this competency, keep doing it just that same way. So letting them know, training supervisors to let them supervise so that supervisee knows what they're doing well. And here's what you did that I didn't think worked very well. Here's why. Here's why it doesn't fit with evidence-informed care or these competencies. And here's what I want you to see. Here's what I want you to do the next time that this particular situation comes up. In fact, let's role play it real quick so you have a chance to practice it. Those very specific behavioral feedback strategies, I think, are important. And I think not giving too much feedback at once. Pick a couple of things that went well, a couple of things that maybe didn't go so well, so that the person being trained or supervised can digest that and isn't saying, oh my gosh, there's so much I can't do. Those are things I think are important for supervisors to do.
That's really helpful, Chris. Thank you.
This is Laura. I'll just chime in. Thank you. That was great. I was thinking about, as you were talking, Chris, like how much, like what a parallel process it is with working with somebody like a patient in a primary care behavioral health model, where we tend to sort of, set up all these elaborate interventions when really just, a simple one or, one would be good enough. So I was thinking about that, the parallel process as you were talking. I think the other thing I was thinking about, just kind of drilling down, getting really specific. One of the things that I think is so important for a supervisor is, to really understand the cultural differences with primary care and behavioral health, from just like how we're trained. And I just can't tell you how much time I spend with my supervisees, just really digging into that piece and grappling with it. That there's oftentimes, especially with new BHCs that are plopped into primary care practices, and witnessing sort of how some of our practices are more trauma informed than others, and some of our primary care providers are more trauma informed than others, relationship with medication. So just being able to sort of hold those things lightly and really be able to dig in with supervisees and allow space for that to come up. those are some of the things that I think about in this area.
I think one thing for me as a supervisor, just to add, is really having some motivational interviewing skills around just their hesitancy around the model and what they've been told or taught in specialty mental health, and some conflicts around that. Just because if someone is not bought in, it can show up in many different places, not just in their words, but in how they're interacting with the team, their patient time, all of those things. I would also say another thing that I've seen as important is how the skills to how to encourage someone to self-monitor. Just because observation, it is there, but when you're training people that aren't necessarily postdocs or practicum, you're training people that are just coming into the workforce. It's very hard to observe them on a regular basis based on your organization. You're not going to get that time. And so how to encourage them to develop the skills of self-monitoring, because if not, it's very likely we're just going to regress to the mean.
And I just wanted to point out two things that are discussed in the article that I find are really helpful. One is the 1-minute preceptor model, the idea of, and again, we use this a lot in medical education, but teaching physicians who have never supervised how to precept. But the first idea is to ask this trainee, what do you think's going on in this case? So get a commitment and then probe for their understanding. And again, I think good supervision doesn't jump in too early to say, here's what I think you need to know, but gets them to say what they were thinking and how they are proceeding in the case. Then you are at a better stage to teach maybe a general rule, correct any errors that you see, and have them move on. The other one discussed in the article are the PARSE model. I'm not as familiar with that. I think it came out of pediatric, but it's also a same kind of model that focuses on how, in especially primary care settings, we can help challenge the learner.
I just want to say thank you to Brittany for that comment about self-monitoring. I think that could be a very useful skill. In Missouri, we have a unique situation. Talk about some unstructured training. We provide training for over 46 organizations across the state, meaning we provide more didactic training on the BHC model, but then actually in the clinic, a lot of, especially in rural health centers, a lot of these people are on their own, and their boss or who they report to is maybe the nursing staff or somebody who doesn't necessarily know what they do. And so we run into a lot of challenges with that. And so that's one of our goals for this year, to kind of tackle how to better inform people who are supervising BHCs on, and I think, introducing them to the core competencies will be huge, so they have something to share, to monitor and share, but also the idea of the self-monitoring, because they're not going to be observing them, because it's not they're not their clinical equivalent. So that's challenging.
Well, along the lines of self-monitoring, can also be monitoring by others, or you could, I'm assuming that there's a peer review process, and so having the provider peer review themselves and then see how that matches up against a colleague who knows what they're doing, who peer reviews them, to kind of see kind of how, when they're looking at their own work, is that consistent with other people. I think there's a variety of ways to do that. With that self-monitoring, if there's a consequence that, ooh, the person that's going to see this thinks this is bad, to fudge a little bit on that self-monitoring. So
I'm doing great.
I know, I think that's,
Yeah.
that's the challenge with this. If there's a potential punishment for pointing out that you're not doing so
Right.
well, people, that's uncomfortable. And so, having those discussions on, our goal is to help you be the best that you can so that you have a lot of fun at work. So this gets easier for you. And so you can work with the team so that you're not getting burned out, to help you engage with that patient the best way you can. I think that can help mitigate that sometimes. And to let them know, gosh, if this feels like a punishment, let's have a discussion with how we can do this differently. So it doesn't feel like that, because I want this to be helpful.
I'm curious for those who did, for the kind of the couple people on the call who received supervision of supervision, if there were kind of certain, I know we're talking a lot about supervisor skills, if there are certain tools that were helpful for you in that, or there were certain models that were used. Was it a similar model of what as a supervisor you would utilize in terms of feedback giving, behavioral recommendations?
I think one thing that was super helpful for me is we did I'm trying to remember what it was called. So conceptualization role plays in our super soup. So I could role play that for my supervisee, because I was an intern, so I was still learning the model myself. And then allowing that kind of conversations to model how I would have that conversation with a practicum student. Also just conversations about having difficult conversations with practicum students. For example, I had a person who, I was lead supervisor that day when another supervisor was coming in, and they refused to take a warm handoff. And so having a conversation about, the reasons why we assigned a warm handoff to her, what was the hesitancy around that, talking about relationships as far as like, would that type of thing have happened if my supervisor was here, and having difficult conversations around that and how that might impact the team. Also, how to give feedback about the primary care team's feedback on that particular BHC. So for example, no one on the team knows your name. So let's figure out how to, get you integrated. If they don't know your name, they're not going to use you. So those types of conversations.
Thanks, Brittany. That was really helpful. And I'm curious for others too. If anyone else has any questions, feel free to. And we always could open it up if anybody's having any challenges in not having a supervisor right now, finding supervisor, wanting to become one, or having challenges as a supervisor with your supervisee. We kind of have some open space in the next 5 or so minutes if anybody needs any consultation or needs some space to talk with others.
This is Laura. The thing I just have been thinking about so much about this topic is, at least in Oregon, there's a lack of understanding at the LCSW board level to really recognize primary care behavioral health and for the board registered associates to be able to count hours, that say they're working with the team versus just the direct hours that they're working with patients, and oftentimes that creating a scenario where board registered associates are having to spend a lot long to get hours, and it's just another reason why they might not select primary care. They'd like to pass along to us, but I know I can see you shaking your head, Kelly, so I know you probably ran into this as well. Just thoughts on that, or
Yeah, what I hear in that too, Laura, is, and I'm curious if other people are seeing this in their states too, who are supervising not just psychology students, other master's level clinicians too, kind of the state regulations around supervision, trying to navigate those within a training program that you have for BHCs, and any advocacy we can do at the board level around supervision. It's so different in every state. As it was astonishing to me that as some in Illinois, as soon as I received my LCSW, I was eligible to supervise the next day. And my agency took me up on that because they were in need. And I felt very incompetent in that as well. But in Oregon, you have to have some level of training, but there's not really oversight of, you just have to submit your CEU certificate. So yeah, it's just very interesting.
I think I'm following the thread here. If I'm not, please correct me. I think there are a couple of common themes I've seen kind of throughout my career is that that I think you can expect in general, your larger professional organizations, although there's been some shifts in this, and or states, professional organizations or guilds, so that they're not going to understand this model of service delivery, and that part of our job is to help them understand that, and help them understand that in a way that isn't threatening to them, because they spent, 10, 15, 20 years doing things the right way, and now you're trying to say that maybe there's another way. So it's not an either or, but helping them understand that it's both. And I think, like anything you're trying to sell, that commercial has to come out over and over and over again. And no matter how many times you said it, somebody's still going to forget it, or somebody's still not going to understand it. As an example, in the military health system, I've now been pushing this since 2008. We have policy instructions, we have robust training, we have mandates to have BHCs or care facilitators, 250 plus for clinics, and there are still people that haven't gotten the message. And so I think that's something that I always have in the back of my mind, and I think can apply to really almost any system or setting.
Yeah, we're providing training and supervision for a person who's starting, needs her LCSW supervision. So that's going to be like an outside supervision while we're training her on the BHC model and providing that supervision. So we're going to hopefully try to also coordinate that with her clinical supervisor to educate that person on the model and kind of help guide, you may see different kind of interventions or different, to try to help with that education with that person one-on-one. I expect I'll have to meet with that person more than once to kind of get through what we're wanting, how we're wanting this person to practice, and that it's clinically appropriate and okay. Luckily we have that ability for this one specific clinic, but it's not always the case.
Thanks, Dawn. I appreciate that. And Chris as well, kind of, it's hearkening me back to what Laura had brought up earlier around kind of this parallel process of sometimes we're then, that sometimes in the relationship with the PCP, we're also kind of advocating and educating on our role and making recommendations. And so we do that with finding supervisors, with the state board, with advocating for our students to get their licensure, to be able to meet these regulations and guidelines, and to improve the outcomes of the model as well. Yeah, well, we have a couple of minutes left. If there are any last comments or questions or kind of takeaways people have from today's conversation, maybe invigoration to attend Stacy's talk at the conference in a couple of months.
I just want to say that, I really appreciate this conversation. I think especially in Oregon, it's kind of still kind of new kids on the block with really trying to move this work forward. So I love it when people get together and have shared experience and share with each other. So thank you for bringing this topic forward.
I agreed. And Brittany shared, structure is important. Absolutely. I think I'm going to bring the article with my supervisee to talk about, and even just to give me more structure, considering the 1 minute preceptor model as well. And like, how am I doing that or not doing that? And just that self-monitoring as supervisor is a really helpful takeaway for me today. All right. Well, yes, thank you, everyone. Thanks, Dawn. Thanks, Chris. Thank you, Mark and David and Melissa and Jackie and Colby and Rosie and Hannah. It's wonderful to see you. Excited to see you all at the conference. Hopefully for those who will be able to attend in person, we'll be able to meet you in person. And then hopefully for those who aren't able to attend, there are still, we'll hopefully find some virtual meeting options, and we'll reconnect with you in a couple of months via our newsletter or anytime in between now and then as well. If you need any resources, if you want to grab from the chat, the BICAT tool and the BHC core competencies, those are also free to access online. So those are not priority. You can use those widely and disseminate them. All right, and we'll see you in October. Okay. Thank you, everybody. Have a great day.
Thanks, Al.